Good afternoon and welcome to today's presentation, The Life Care Planner as Expert Witness, Whom Do You Trust? Before we begin our presentation today, I would like to take a few moments to go over some housekeeping items. We will be recording this webinar, and this webinar is CLE approved, and we'll be asking that you enter a passcode for CLE credit a few times throughout the presentation. In today's webinar, Ms. Howland will discuss the differences between life care planning certifications, preparation and methodology, skills for selecting the appropriate life care planner for a particular case, and strategies for deposing an opposing life care planner to expose strengths and weaknesses in his or her testimony. To give you a little background about our presenter, Wendie Howland, she is a medical cost damages testifying expert in life care planning, offering expert life care plans for plaintiffs and expert critiques of plaintiff plans for defense. In addition to her private life care planning practice, Howland Health Consulting, she is the editor for the Journal of Nurse Life Care Planning and develops the core curriculum for the American Association of Nurse Life Care Planners. She earned a bachelor's degree in nursing from Boston University and a master's degree in physiological nursing and critical care from the University of Washington. Ms. Howland holds national certifications in rehabilitation, case management, life care planning, and legal nurse consulting. For those of our attendees who require a code word for tracking purposes, the code word for today is CARE. During the presentation, we will take short breaks, and during that time, we will ask that you enter this code into the Q&A widget for CLE reporting purposes. The Q&A is located to the left of your screen. Please remember that if you're applying for CLE credit, you must log onto your computer as yourself. Also, please remember to complete the survey that will appear to the right of your screen at the end of the presentation. As a provider of CLE credits, we are required to have supportive information that you have attended, and in many states the survey is required. CLE certificates will be provided within 24 to 48 hours via email. CLE credit is only available to those who have attended the live presentation. You are not eligible to receive CLE credit if you view this presentation on demand. Also, the PowerPoint slides can be downloaded from the resource list on the left of your screen. Ms. Howland welcomes your questions. Please use the Q&A widget to submit your questions throughout the presentation. We will take intermittent breaks so that Ms. Howland can respond. Thank you all again for attending today, and Wendie, the presentation is now turned over to you.
Emily, thank you very much for that nice introduction. And I'm very glad to have this audience because I live in a state where there is no required CLE, and I don't get nearly enough opportunities to explain what we do as life care planners to attorneys. So thank you very much for coming. This is the standard conflict of interest disclosure, which I don't need to read to you. But I'll leave it up long enough for you to read. Okay. So the objectives I have here are to describe the differences in life care planning certifications, prep, and methodology. A lot of people don't realize that there are major differences in these aspects, and I think that if you are looking to engage life care planners or if you are defense to critique life care plans that are submitted by defense, you should really be aware of some of these things. I would like to help you be able to select the best life care planner for a given case and look at how you can depose an opposing life care planner to make sure that you understand their strengths and weaknesses. And this is the big one. I would really like you to be able to understand how these aspects affect credibility and reliability. A life care planner is not a life care planner is not a life care planner any more than a lawyer is a lawyer is a lawyer, or a nurse is a nurse is a nurse. I kind of like this cartoon, so I put it in for a small bit of levity. You do not want to have somebody who's going to testify as an expert who doesn't really know as much about it as you hoped. What is a life care plan? I know a lot of attorneys are very confident that they understand what life care plans are. Briefly, there are tools to estimate medical and non-medical damages, and they are based on published standards and, most critically, assessment, analysis, and research. Okay. Some people think a life care plan is merely a set of charts with numbers on it. A good life care plan has a great deal more than that. It should include all of this information and the rationales for why the life care planner decided to include all these different aspects of care. And as you can see, it's not all just medical information, which is very important when you get down the line to who's qualified to do life care plans and prescribe what parts of them. Okay? But a good life care plan includes pretty much anything that will incur costs related to the client's injury or illness. There are many different ways for people to come to life care planning. They may or may not be certified life care planners. CLCP is one credential for life care planners. Many life care planners are, come from these different disciplines. And you may even have somebody on your staff who is tasked with looking at life care plans or giving you what are frequently called medical cost projections, which are different, and we can get into that a little bit later if anybody has a question on that. However, I'm a nurse life care planner. I'm a CNLCP. There are 2 nurse life care planning credentials, and these are their respective certification boards. And I would like to explain why a nurse life care planner is probably going to be your best bet in a number of ways. These are the qualifications for any certified nurse life care planner. And I don't need to read these all to you, but the last one is really important. We legally diagnose and prescribe interventions for human response to illness or injury. This does not mean that we're all nurse practitioners, because while nurse practitioners have prescriptive authority for a number of things that are otherwise reserved to physicians, any registered nurse, as a consequence of the Nurse Practice Act in the state, or if you live in, say, Michigan, where there isn't a Nurse Practice Act, we are bound by the American Nurses Association Scope and Standards of Nursing Practice. We are bound to legally diagnose and prescribe interventions for people who have been hurt or sick. This is the ANA definition, which you can look up. I seriously suggest that you get a copy of the Scope and Standards of Nursing Practice, because it will surprise you. We are into diagnosis and treatment of human response and advocacy. Advocacy is big here in the care of individuals, families, communities, and populations. Where do life care planners work? Most of us are independent. Some people who are life care planners work for insurance carriers. They may, in that capacity, they're most likely to be preparing medical cost projections so the carriers can set reserves. Those of us who are independents or work for independent case management or life care planning companies work only for plaintiff cases or only for defense cases. A number of us do both. I do both. I find I can sleep better at night. The plaintiff people think I'm too conservative sometimes, and the defense people think I'm too generous, and so I figure I'm probably hitting it about right. CLCP life care planners who are not registered nurses must work from a medical diagnosis. And why is this significant? Well, because there's a lot more to all those aspects of care and all those things that people need that don't necessarily have to do with the medical diagnosis per se. And because of this, many people who are not registered nurses and do not have the background in patient care and prescription and planning that registered nurses have work from a proprietary software program. There are several of them on the market where you put in the medical diagnosis and some demographic bits of information, push a button, and you get what's called a life care plan, which has all the interventions that should be done, all their costs, And some of these programs also will spit out a bibliography to support their inclusions as necessary. There's a problem with this because many things in those algorithms are not possible to assess by a number of people promulgating them because they're outside of their legal scope of practice. And we'll talk about that in a little bit. And nobody except nurses and physicians who can diagnose with medical diagnoses only can make diagnoses. There is such a thing as nursing diagnosis. I'm going to talk about that a little bit. And once again, not only can they not assess outside their scopes, they cannot prescribe outside their scopes. This turns out to be a very interesting proposition. This is the scope and standards from the ANA, slim little volume. I once took it to a deposition, and the deposing attorney took my copy, handed it to a paralegal, and said, go make copies of this. I pointed out that you could get this from Amazon from overnight shipping a lot faster and probably less expensively than having your paralegal spend the afternoon at the copy machine. But there it is. Okay, the nursing process, which is our framework for life care planning, starts with a nursing assessment. And nursing diagnosis does not derive from a medical diagnosis. This is completely a product of the nursing process, and I'm going to show you why this is not inferior in any way and is actually going to suit your needs better. These are the past, some past, and the current volume on nursing diagnosis, definitions, classification. These are actually scientifically validated, and this is the authoritative version, so you should have a copy of this in your office also. Okay, does anybody have questions about any of this before we move on?
Could all the attendees please type the passcode into the chat feature? Our first question is, could you please state the title that they should look for again when retaining a life care planner?
There are several different certifications for life care planners. The Nurse Life Care Planner is a CNLCP for Certified Nurse Life Care Planner. There is also another nursing certification, which is the LNCP-C, which is Lifetime Nurse Care Planner Certified. Okay. The non-nurse certification is CLCP, and that can be anybody who is not a nurse, although there are some nurses who are CLCPs. Go ahead.
And is there special education for a nurse life planner?
Yes, there is, and I can go into that. Like for many other specialties, there are not necessarily educational requirements. However, for the CNLCP certification, you have to have had at least a course in life care planning. You have to present a life care plan for review by the certification board, and you have to have had at least, I believe it's something like 2,000 hours, possibly more, doing life care planning work, which has to be documented. That allows you to sit for the CNLCP examination. Okay? Does that answer that question?
Yes. Does the nurse have to rely on the medical diagnosis?
Not for nursing diagnosis, and I can get into that in a bit. Okay? Good question.
Okay, and do life care planners collaborate with other medical professionals?
Absolutely. One of the prime responsibilities of nursing in any setting at all is collaboration with all of the treating team for any patient. If you're a patient in a hospital, your nurse is the only person that speaks to dietary, physical therapy, physicians, pharmacy, everybody. And we continue that outlook on life into life care planning also. Good question.
Are all life care planners certified?
No, of course they're not. No one has to be certified in anything. I'm also certified in legal nursing, and I know there are many legal nurses who are not certified in that. People hire them because they have nursing knowledge. I think that certification in general is validation for someone's educational preparation and experience, and I would personally not engage anybody who wasn't certified. Good question.
Okay, and this person is looking for a CNLCP in Richmond, Virginia. Is there a registry or list somewhere online or in a library?
You can go to the website for the American Association of Nurse Life Care Planners, www.AANLCP, and there is at the website a Find a Life Care Planner section.
Okay, and what are the benefits?
Go ahead.
One more question. What are the benefits of having a life care plan?
I think the most important benefit of having a life care plan is to really have a good idea of what your client's needs are going to be as a result of his injury or illness. Because if you only look at medical needs, what surgeries is he going to need, what drugs is he going to need, how often is he going to have to go to physical therapy, that kind of thing, you miss an enormous part of this person's life. And if you do not have a good nurse life care planner to tell you how to provide for those needs over the patient's anticipated life expectancy, then the money's going to run out, and so many things that are going to be needed as a consequence of the injury or illness, there will be no way to provide them. So that's the major reason you're going to want a life care plan for anybody with any kind of catastrophic or long-lasting condition. For example, some people have chronic pain, which may not have happened because of a catastrophic injury. It might have been a comparatively small injury, but it's become catastrophic over their lifetime, and the insurance company that's paying for their care feels it's catastrophic from a financial standpoint. So there are all sorts of things that a nurse life care planner is primed to look at and to fill you in on that you might not be aware of. It's always worth asking. I love that question. Okay, shall we move on?
One more thing. Could you please repeat the question or the website to look up the certified life care planner?
Sure. It's the American Association of Nurse Life Care Planners, www.AANLCP.org. And look for the Find a Nurse link.
And what time should a life planner be hired in a case?
What time did you say?
At what time, yes.
At what time? As early as possible. As soon as you have identified the case as meritorious. A number of us do legal nurse consulting too, so we can help you with some of those issues as we do our medical record review. But I will tell you that it takes a good long time sometimes to do a good life care plan. And if you call up one of our certified people and say, I need a life care plan for mediation in 10 days, nobody will do it for you because no one will be able to do a credible job in that short period of time. Good life care plan will take 6 or 8 weeks. So count backwards and give us as much time as you can if you want the best job possible.
This person asks, with that description as to why I would want to hire a life care planner, why would I want to hire you to defend a case?
So this is a question from the defense. Okay. From the defense standpoint, I would evaluate the plaintiff's life care plan to see whether it's excessive, whether there's duplication in it, whether the pricing is questionable or sketchy, whether the methodology is good. I'm going to get into a couple of different kinds of life care plans a little bit later on. So how about we do that, and I'll be able to answer that question a little more in depth at that point. Okay?
Please keep going with the presentation.
Thank you. Okay, we're going to look a little bit at methodology, which is something that's going to be important to you. We're going to look at a very, very fast review of what's a taxonomy. Oops, that slide is not going to come up. So we will skip that. We will look at this one. This is, don't groan, I know some of you took this in school. This is the hierarchy of knowledge based on hierarchy of knowledge. So the very beginning is you know something, you remember it. If you're a little bit better, you understand it. If you're a little bit more knowledgeable, you can apply it. And a lot of people stop right there. But if people with more and more competence and experience go to analysis, evaluation, and actually get to the point where they can create knowledge. Okay? Now, why do I have this in here? Because remember that life care planning software that I talked about earlier? There's lots of knowledge being remembered because it's in the database, and there's a fair amount of describing and explaining. And there may be some application, but unfortunately, the analysis and evaluation, much less the creativity, are often lacking, and that's usually as a result of the base licensure of the person who is using it. Okay? And why do we care about this? Well, everybody knows Rule 702, and the important part here is that the testimony has to be based on sufficient facts or data, and the testimony is product of reliable principles and methods, and the witness has applied these reliably to the facts of the case. You will get to decide, or the judge will, whether the sufficient facts or data are met by a life care plan that's based on a software program. And I submit that a number of these such plans are not supportable. And I can tell you why that is. Part of that is the reliable principles and methods, because a lot of this is based on old information, and it is being promulgated by people who, again, do not have the base licensure to do what they're doing. And they may or may not be applying these principles and methods reliably. Okay? Who knows the underlying data of all these things that you are going to have collecting in your office for a big case? Medical records, medical billing, claims records, depositions. All that sort of thing is exactly what nurses understand and know. I can't tell you how many interesting things I've found in depositions that my attorney client didn't realize was significant, but that substantially made a difference. Also, medical records. You can find a lot of very interesting things here. Billing is an interesting question. I know that the recent cases in California that are talking about costs, projected costs relating to past billing, there's a lot of controversy about this. Past billing, as we all know, is no guarantee of future cost. And if you think it is, then I suggest you call up your electrical utility and tell them you want the same bill you had 10 years ago, because that's not going to happen. Anyway, the nurse is the best person to answer these questions because we have more extensive knowledge of all of these different areas than just about any other profession. And everybody says, well, why don't we just ask the doctor? Well, there are a number of reasons why a physician is not going to make your best bet for a life care plan. There's a movement afoot now where a number of physicians have discovered that this could be a pretty lucrative market for them. And they offer, quote, life care plan, unquote, for a fixed rate, which looks extremely reasonable. The problem with these is that they don't usually personally assess the subject of the life care plan. They usually work on medical records. And so did they send somebody out? And who did this evaluation? What kind of methodology did this person use to identify needs, costs, and all this other stuff? Were they working off the same software? Yep, maybe. That happens quite a bit. Did this person prescribe all the components of a life care plan? And do they have experience and education to do this? Now, I understand that many people feel that everything needs to be prescribed by a physician. I get asked this in deposition fairly often. Said, no, Nurse Howland, you can't prescribe anything because you're not a doctor, are you? And the fact of the matter is that prescription of some things is limited to physicians. For example, a nurse who does not have prescriptive authority, like a nurse practitioner, cannot prescribe medications, cannot prescribe or do surgery, and other sorts of things like that. Certain kinds of medical equipment cannot be prescribed by a nurse. However, it's very important to realize the difference between prescriptive requirements under scope of practice and prescription requirements as a financial control measure by an insurance company. If you want to go out and buy a $6,000 wheelchair for your injured family member, and you go to a reputable vendor and you have it properly fitted and sized and get all the proper gadgetry that this person should have, that's great. You cannot then tell the vendor, send the bill to Blue Cross, because Blue Cross or Fallon or whoever else will bounce that because it's not prescribed by a physician. It's not that the physician knows all the gadgetry that the patient's going to need. The physician doesn't know how to fit a wheelchair, doesn't know how to measure it and how to order all the gadgetry that goes with it, and there's a lot of gadgetry that goes with a wheelchair. It's that the insurance company will only pay for it if a physician says it's necessary. Now, with a life care plan, the patient's going to be on a self-pay basis. So the vendor doesn't care who prescribes it. I wouldn't prescribe all that gadgetry either because I don't know it, but I would certainly be well within my scope of practice to prescribe an evaluation by a qualified wheelchair specialist and then get that and get the results from that and then project the cost for that and its replacement interval and all that and all that. A physician cannot do that. They can't. But the one thing that physicians, some people sometimes think physicians have to do is prescribe nursing care. That is not true. And actually, if you look up in the scope and standards of nursing practice, you will find that the people who prescribe levels of nursing care and the people who do it are registered nurses. Why do we care about that in life care planning? Because the most expensive component of any life care plan is the extended care, the extended nursing care, the home care, the assisted living, nursing home care. There is no way that a physician has the experience or education or training to prescribe nursing care. And everybody says, well, a physician has to write the order, has to prescribe for a visiting nurse. Once again, this is a financial control method. If you go to any visiting nurse association, they all have a private pay division, and you can go on a private pay basis if you're not expecting money from an insurance company to cover this care. Just as when you're a hospitalized patient and your physician writes VNA to evaluate and treat, the VNA is the one who evaluates how much nursing care is needed, what level of care is going to be provided, and how many hours of each are going to be appropriate for that patient. The physician has no way to do that. And so when someone who is not a registered nurse puts hours of nursing care and levels of nursing care in a life care plan, if that life care planner is not a registered nurse, that's all very easy to contest because where's their experience and licensure to do that? So that's one reason why you don't just ask the doctor. I know a lot of the CLCP life care plans get, quote, signed off by a physician. That doesn't necessarily guarantee you that the contents of that plan are appropriate because physicians, as I said, aren't always able to prescribe anything. Okay, moving on. Does your life care plan expert work only from the medical diagnosis? This is a red flag, as I said, because if all you do is say, oh, this person has a C6 incomplete spinal cord injury, therefore he's going to need this, 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 and this, and this. You don't know that. He may need more. He may need less, depending on any number of individual factors. So if all you do is say, this medical diagnosis requires that, you're seriously missing the boat, and both for plaintiff and defense. Okay. We talked about assessing outside of licensed scope and making diagnoses outside of scope and prescribing outside of scope. And we talked about using these algorithms which may not and many times do not meet individual situations. Okay. Now, we have, I've got a number of a couple of pretty interesting examples from actual life care plans that I've either done myself or been asked to critique. This is one page from a life care plan that was done by a physician. And this is a young woman who had multiple orthopedic trauma after having been hit by a vehicle that belonged to a city. And so I was working for the defense for the legal department of this city. And we got this life care plan to look at. Now, I hope you can read that. But things are a little bit, shall we say, non-specific. And I couldn't defend some of these costs if I was asked to. For example, here's a cane for $35, replaced every 2 years, for an annual cost of $17.50. I don't know about you, but I have a cane that my grandfather used, and it's still fine. You can get an extremely good cane for $10, and it'll last you for 10, 15 years. So this is excessive. The AFO, that's a brace. They do not cost nearly $1,200, and you do not have to replace them every 2 years, and she didn't even have one. Manual wheelchair, $3,300. You can get an extremely serviceable manual wheelchair for, you can get a deluxe manual wheelchair for about $200. And this woman didn't use a wheelchair, didn't want a wheelchair. Wheelchair cushions do cost $450. They're usually used for people with spinal cord injury who have no sensation, so they get pressure ulcers, and they need to be replaced every 1 year, not every 3 years. But somebody who does not have that kind of sensory deficit and is not paralyzed doesn't need that. And certainly, so all this was completely speculation on this gentleman's part, because I don't think he ever looked at the actual patient. This is a woman who was walking 6 city blocks to go to her physical therapy. She didn't want a heavy-duty scooter. It says it needed at this time, obtained when she is willing to accept need. She doesn't need it. She doesn't want it. And also heavy-duty, by definition, is for people over 350 pounds, and this woman was about 5'4" and weighed about 150. Additional medical care. This is all very nebulous. I would never be able to defend these sort of numbers. PT/OT based on past bills. Again, we don't know that, and we don't know that she's going to need it. And it says quantity, 20 to 30. 20 to 30 what? Is that per year maybe? I guess it probably is. But this is a woman who has been discharged from physical therapy because she has met all her goals. Weekly house cleaning. Occupational therapy evaluated this woman and found that she was 100% able to do all her own shopping, house cleaning, and she was doing this. This is one of my favorite ones, child care. If she should have children, child care is $15 an hour. What does that mean? So it was really very easy to discredit this, quote, life care plan, unquote, even though it was written by a doctor. This is more from the same one. None of these prices checked out when I went to find them. So, those are very easy to discredit. There was also no guarantee that she was going to need any of these things. It is possible that she might need a hip arthroplasty or total knee, total hip, because of wear and tear on her joints were injured as she aged. That's possible, but there was no reason to assume that she was going to need 3 of each, and the costs were not supportable either. So that was a a very interesting case, and I had very little trouble getting that life care plan withdrawn. This is another interesting case that illustrates some of the problems of using someone who uses a computerized program to determine what is necessary. This is a 72-year-old gentleman, had a spinal cord injury. SP stands for status post. The computer program said that he would need a live-in homemaker, which would cost almost $71,000 a year, room and board for a live-in, all these things that are on this slide. Okay. Plus, down at the bottom, a whole new built wing for this person to live in, and all this equipment, and all of that was in addition to the $137,000 for these caregivers. This is for private care in the home. Okay, this is if you go and just hire somebody, a nice lady from the church or from a home care agency. Agency care, same kinds of caregivers for more cost, and that's common because the agency needs to make their nut, and they have costs for running the agency. But because this person that wrote this life care plan was not a registered nurse, did not recognize that this patient has medications and other needs that require registered nurse level of care, which would have cost $280,000 per year for a 24-hour RN. Okay, so there was a problem right there with that. The other things you can probably see is if you look at this, is all these hours. 4 is 8, 8 is 16, and 16 is 32 hours a day of care, but some of these he's going to be in a day program. So what are these caregivers doing in the meantime? Also, if he needs 24-hour awake care, why do we need a whole bedroom and sleeping room for the caregiver? We don't. Okay? So somebody just pulled this out of this computer program, and here it is. So this is the kicker. This man was living in a skilled nursing facility. He liked it. He was very happy there. And everything that was on those previous charts, including all the equipment and everything, was included in that 86.8. And, the case management and all the supplies, all his drugs, his everything. And he doesn't want to leave. Now, I understand the difference between a life care plan that's made for actual life care planning purposes and one that's made for litigation purposes. But I thought this was actually egregious. So that was another plan that was pretty easy to contest. Okay, this one is this is a case that I did. The next couple of slides are some that I did. This was a lady this is a very small part of her life care plan, I want to tell you. This is a lady who had very severe burns, and she was injured in an explosion. The problem with that was that she actually got pretty bad care in the burn unit where she was in because they discovered she had no insurance, and so they kind of hustled her out of there more or less as quickly as they could. Standard of care for anybody that has any kind of explosion is to do neuropsych eval because you can have a brain injury. Many people do. She also had very low blood oxygen, that's tissue hypoxia, because she had burns in her lungs, and that can damage your brain. She'd never had any of that done. She had actually had no care at all for 2 years at the time I met her. And all of these things are initial evaluations. I was deposed on this case, and this was one of the ones where they said, well, you can't prescribe these things. I can prescribe an evaluation. I have the education and understanding and ability to say this person needs to have an evaluation for these different services. And what happens after that may depend on physician prescription, or may depend on physical therapy prescription, or a driving safety prescription. Okay. She also had eye injuries, in part because they didn't take her contact lenses out for 6 weeks. But aside from that, She had burns in her eyes. She also had no counseling at all, which is standard of care for burn patients. And she had children, and it's also standard of care to do counseling for burn families because a catastrophic burn affects an entire family. She had also had no pain management, and here she was more than 2 years post-burn, and had terrible pain and was not sleeping. She, all of these things in italics, these are all nursing diagnoses, which are made by registered nurses on very specific sets of findings. Just as your physician can't diagnose anemia without doing a blood test, so nurses can't make nursing diagnoses without having assessment data. And this lady had all the symptoms of post-trauma syndrome, which is not the medical diagnosis of PTSD. And I got challenged on that, but I have data for that. And she had many, many things that were seriously affecting her life. So I put all of these in the life care plan because this was care that she needed. Okay. And these were some of the things that I felt that she was going to need based on my experience with the kinds of therapy that she was going to need. And once again, this is based on an individual assessment, which your computerized program cannot give you. Okay, this is from a different patient, and I included this slide to show some of the ways you look at costing in a life care plan. You should never get just numbers with no substantiation. The numbers I had back here on the patient care, these costs, CPT codes are standardized, and the prices you can get from I have a book by PMIC that gives medical costs in the United States for every CPT code, and there's a geographic modifier for the difference between New York City and rural Nebraska and so forth. All of those prices are footnoted as defensible. This is the clarity and the transparency is required in life care planning. If you just get a list of numbers with no list down the side of it, well, I called Spin Life, and this is what this Tilton Space shower chair is going to cost. I called Invacare about these things. I checked a couple of different kinds of pumps to see what the high and the low prices were, and I justified over here management of feeding tube complications requires that these tubes do get changed every day, and that's why it costs what it costs. All of this is all footnoted and all noted so you can check it. And so if you're defense and I give you this, then you know what you're going to have your client reserve. And if you're a plaintiff, then you know that when you ask for these numbers, they're supportable. Okay, deposition. We've all been there. Okay. Once again, I hate it when presenters say once again, but this is such a critical point. You really need to know this. Where's the scope and the licensure for the person who's presenting themselves as a life care planning expert? A social worker who does life care planning, a vocational counselor who does life care planning is not licensed and does not have scope of practice to prescribe nursing hours, to prescribe evaluations. They don't. Witness had been doing so well at his deposition when suddenly it's really important, as I'm sure you know better than anybody, that your witnesses don't make it up as they go along. One of the great things about a well-written life care plan is that it's all there. All those numbers are there. The references are there. The bibliography actually refers to the actual case. It's not just a canned bibliography on a C6 spinal cord injury. It's things that relate to this individual case, and it's defensible. Okay, we all know about Daubert challenges. Is this life care plan made for litigation or for purpose of testimony? Is there a big gap between accepted data and opinion? Well, I think that if you have a well-written nurse life care plan, you're not going to have this gap because we cite everything. We cite our references, and we're licensed to make these judgments. Okay. The discipline has reliable results to support the opinion. That also goes to base licensure and scope of practice. Obvious alternative explanations. Nurses spend years and years and years looking at alternate ways to do things. It's our responsibility that if one thing doesn't work, we think of something else. And we have, especially someone who's been a life care planner and has been a nurse for a long time, has seen a lot, and we have a lot of alternatives in mind. Okay. The other thing is you need the same level of academic rigor in practice as in testimony. Life care planning is a nursing practice. It's a specialty, and it's what we do. Okay. So when you go to deposition or you've put out your interrogatories, you want to ask, what's the basis of your practice? Do you do anything else besides testify? And I know this is Deposition 101, and probably a number of people listening here know this, but it bears repeating. When you know the difference between education and continuing education requirements for life care planners, you can really hone in on how credible this witness is going to be. Does this person publish? Does this person give presentations? Someone who gives a lot of presentations is going to make a better witness. Somebody who does a lot of publication that has developed a reputation in the field for expertise is going to be somebody who you might trust more than someone whose major accomplishment in life care planning is taking a course that teaches them how to use this computer program. And always ask about plaintiff defense percentage. As I said, I do roughly 50-50, which I feel makes me more credible. We all know what we call people who just do one side or the other, and I'm not going to say that here, but this is not the kind of person you want working for you. Okay, these are questions to ask about methodology. Does this life care planner interview the patient, the family, and the caregivers? Find out what the patient's and family's goals were. Remember that gentleman who was in had the spinal cord injury, who was in the skilled nursing facility? He and his family were thrilled to death with the care that they were getting, but nobody asked. You have to interview everybody in the treating team if they're available to interview. That was one question someone asked about, do you work with the other members of the team? Of course you do. You have to know everything as much as you can from everybody. On that burn case, I got dinged by a defense critique for not interviewing treating physicians. But if the person that wrote the critique had actually read my report, which I'm not 100% clear that he did, he would have noticed that there were no treating physicians. He actually contacted one of the people that cared for this woman 2 years previous and asked him for opinions on what care she needed, and he declined to say because he hadn't seen her for 2 years. And that was actually in the critique, so I actually felt sorry for the people who relied on this critique because it was really very easy to rebut. Did this person go out and look at the home? Do you really need to have massive home modifications? Conversely, have home modifications been done already that really weren't appropriate or useful? I had a wonderful case once, actually it was a fairly sad case, about a gentleman who was a volunteer firefighter. And he had a freak accident at a scene and was paralyzed from the waist down. And all the guys from the firehouse, a lot of them were, did construction and plumbing and other things when they weren't being firefighters. And they came out and they built him a big new bathroom on the side of his house and all that. The problem was they had no experience in doing this, and it was completely unusable for him. And if he had had a life care planner to look at this ahead of time, that life care planner would have recommended a couple, not just one, but a couple of reputable people who were certified in home modifications for the handicapped. There are people like that, and we know who they are. Services and equipment in use. There's no point to prescribing a wheelchair when the patient doesn't need one. There's no point to prescribing a heavy-duty scooter if your patient weighs 115 pounds, much less if she doesn't want one or doesn't need one. And licensure for the evaluations listed. I don't make recommendations for home modifications because that's not my area of expertise. However, I do have somebody to go out and take a look at the house who is qualified and give me a ballpark estimate. I don't just automatically say, I'm going to need all this stuff and it's going to cost this money because that's what my database says. I'm going to have somebody go and look to see. Okay. We talked about software. We talked about prescriptions for plan of care and authority to make them. And look at the costs. What are the source of those costs? Is this from a database that you compiled when you did a similar case 5 years ago and you're just going to pull up those same numbers? I can always tell when that's happened because when I get the tables, it's a male patient and it'll say for her lifetime. And I'm thinking, okay, that's a cut and paste job, but it's not current and there's no source. And we're going to talk a little bit briefly about annual costs versus the whole item. Okay, what is that? Well, let's see. This is one of my favorite Daubert slides. I don't have any accurate numbers, so I made this one up. Studies have shown that accurate numbers aren't any more useful than the ones you make up. How many studies showed that? 87. Okay. You can't explain it simply. You don't understand it well enough. Thank you, Albert Einstein. Okay. This is the example for the idea of looking at costs on an annual basis. Example here. You have a $6,000 chair. You're going to replace it every 5 years. That's what the Q is for, sorry. And the life expectancy for this patient is 12 years. So some people will say, all right, $6,000 divided by 5 years, $1,200 a year. Life expectancy is 12 years. Therefore, we're going to put in $14,400 in the life care plan. Problem with that. If you're just buying this chair now, at year 0, over here on the left, the second time you will buy it will be at year 5, and the third time you buy it will be at year 10, and that'll be the last time you buy it because the life expectancy is 12 years. Total cost of those purchases is $18,000. So if you only put in $14,400, you don't have enough money to replace this gentleman's wheelchair. However, if he's in the chair now and he got it 2 years ago, your first purchase is going to be at year 3, the second will be at year 8, and that'll be your last purchase. And the total cost will be $12,000. So if you've allotted $14,400, you've padded the bill. This is the problem with looking at annual costs. Okay? You can do annual costs for things like hours of care or doses of medication or boxes of dressing change supplies, but you can't do it for big-ticket items like this. Okay. I love this cartoon. We're trapped. There's no exit. We'll have to improvise. We pull down that beam. There's rope. Rope's good for tying, guys. We can dismantle that fridge that Dave's leaning on. It's not a fridge. It's a teleporter. Because you didn't ask. That's why. Nurses know what kind of questions to ask about these sorts of things. We go into someone's home, and when the patient says, I wanted to go home from the nursing home, but then the day that I was supposed to go, I just refused to go. And some people would say, well, he was nervous, or he was worried about getting in the car, whatever. I looked at this gentleman and said, it's about the briefs, isn't it? Because as a result of his stroke, he was incontinent, and he didn't want his family to know that he was wearing briefs for incontinence. Even if they never changed him while he was home on the visit, even if there was no odor, there was nothing, he just didn't want them to know. And that was it. So we worked on that problem. Okay, here we have for more information. I believe this is in your handout. You can get the ANA scope and standards. You can get the nurse life care planning scope and standards of practice at our website. You can also look at the core curriculum, which is a very interesting book, and I wanted to correct one misapprehension from an early slide. I didn't develop the core curriculum. I was the editor for the first edition, and I'm in the process of editing the second edition now. There's also the IARP Standards of Practice. These are standards of practice for the non-nurse life care planners. And that's my presentation. You must have more questions by now, so let's hear it.
Could all the attendees please type the passcode once again into the Q&A? Our first question is, what kind of case is meritorious or needs a CNLCP?
Well, we don't decide merit. Attorneys decide merit. However, if you want to know who would be a good patient or a good client to engage a life care planner, it would be anyone who's going to have lifelong needs of some kind as a result of the injury or illness. For example, someone with a traumatic amputation. It's not just a matter of, oh, well, he's going to need a leg prosthesis, and those have to be replaced every 3 years, and so we'll buy one prosthesis and we'll multiply that out, and that's all he's going to need. No, he's probably going to need more than that, because as he ages, his using a prosthesis, even a really, really good one, and there are some fabulous ones on the market now, uses more energy than just walking on your native leg. And so when you get older and your body is aging, you're going to need more assistance and more compensatory gear and maybe architectural modifications at a younger age than someone who didn't have the amputation. So you might want to have a life care planner look at that case to give you a little bit better idea of what you don't want to leave on the table. One of the things I tell people all the time is that when I work for defense is that if that's all the plaintiff is asking for, write the check with a smile, because this is not adequate for this person. I'd say anybody that has any kind of major injury, and catastrophic injury is defined as traumatic brain injury, amputation, big burns, multiple trauma, spinal cord injury. If you have anybody that has one of those, you probably want to look at a life care plan. You might also want to consider that some injuries don't jump up and say, this is serious. I'm doing a case right now of a child who looks pretty normal, and he's a very engaging young boy, and he's polite, and he's runs around, and he doesn't have any coordination. He has some coordination difficulties, but he suffered a brain injury, which is probably going to affect him for his entire life in various ways. And one of the things I discovered was that his physician evaluations had missed a couple of very critical points. So that was something that I was able to pick up based on my experience with life care planning. I hope that answers your question.
The next question is, why do you assume a plaintiff will be self-pay when preparing the life care plan? If they have Medicare, insurance, etc., shouldn't that be the basis to go on from in terms of figuring out the costs?
It's an interesting thing that you say that. For one thing, there's a thing called Medicare set-asides. Long ago, when I first started doing field case management, which is how I started in this whole field, the workers' comp carriers counted the months until their injured workers became 65, so then Medicare would take over their costs. Medicare, of course, tumbled to this, and then regulations were passed that any settlement had to keep Medicare's interest in mind, because they weren't going to pay for things that were the result of someone else's negligence. They are expanding that from workers' comp to general liability, and although it's my personal opinion that eventually with the Affordable Care Act there's going to be an equivalent for all insurance, that's not in the books now, but I think it probably will be, because the idea of a settlement is not to, is to pay for your negligence. And you shouldn't be able to dodge that because there's another form of insurance. And, of course, the other form of insurance doesn't want you to dodge it either. So that's part of the thing. We are not, as life care planners, we look at today's costs in today's dollars with the best estimate that we can make of future needs. And as an aside, we recommend that any life care plan get re-looked at every couple of years, depending on how stable people are, because we are not allowed to consider collateral sources for funding, because those might not be there tomorrow. Your Blue Cross might go out of business, and whoever comes up may not be able to cover that. So that's the answer to that question. We cannot consider collateral sources because we can't guarantee they're going to be there, and if we assumed they would, then we would be leaving the patient vulnerable to risk of not having his needs met.
And how does the defense obtain an interview with its CNLCP? Such an exam or interview is not required per code.
How does the defense get an interview? I'm
yes.
sorry, I don't. Do you mean with the injured patient, with the injured person?
I think maybe with
go ahead.
CNLCP.
The short answer is you call up and make an appointment. But if the question is, can the defense life care planner go and visit the injured person, that would be up to the plaintiff's attorney, generally speaking. There may be other statutory remedies for that. That's not my area of expertise. But if the defense just wants somebody to look at a plaintiff plan, call me up or call up another CNLCP and engage them.
And isn't any life care plan subject to objection as speculative going far into the future?
Of course it is. And the thing is that, it's funny you should mention that. I have another presentation on common objections to life care planners, or life care plans in general, and that's one of them. Well, this is all speculation, isn't it? Well, it is and it is not. And I know speculation has a very particular meaning in the law. It is not speculation in that we are educated and experienced in and are supposed to know what, to a reasonable degree of certainty, someone with a given condition or injury or whatever is, in fact, going to need as they age. There's a considerable amount of research and literature on, you name it, the things that happen over years to a spinal cord injury, that happen over the course of years with a burn or a brain injury or whatever else. So in that respect, it's not speculation at all. We do the best we can with what the literature and our experience and education tells us.
And what sources do you use for life tables? Also, which sources do you use to look at appropriate fees for equipment, medications, and medical care? Well, for the second one's easiest. For medical care, I look at the PMIC medical costs in the United States, med fees in the United States. That's compiled by, I believe, the AMA, their publishing arm. They have data from everywhere in the country on what's billed and what's paid, and so that's a pretty good source for fees, and nobody's ever challenged me on that. For equipment and supplies, you call up the vendors. You call up a couple of them. Some people say you have to call 3. There's no real standard for that. It depends on availability also. I use a lot of online sources because many online providers of equipment do free shipping, so it's really, it's an easy way for someone to get something delivered to their home. They have to go and pick it up or buy it themselves and get reimbursed, and so that's pretty handy. And there are also some things that you can't get estimates from 3 different vendors because 3 different vendors don't sell this particular gadget. For example, if I ever had to have my lower leg amputated, I know exactly whose foot and ankle prosthesis I would want, and there's only one company that makes them, and that's what I would have in my life care plan. As to, I'm sorry, what was the first one on that? You said equipment and vendors, and what was the first part of that question? To refine the question for you, what sources do you use for life tables?
Life tables, of course. Well, for MSAs, the government requires you to use the U.S. Tables from, I forget who puts those out, don't have that in front of me, but they require that you use the numbers for all citizens, regardless of gender or ethnic background. However, it's probably more accurate to look at the breakdowns they have for white, black, Hispanic, and non-black, non-Hispanic, and male-female. And I use those. You can also look at, those are for general purposes. There's a lot of research out there to give life expectancy estimates for different medical conditions. For example, spinal cord injury. There's a whole set of tables from the U.S. spinal cord model systems data that say if you are 40 years old and you sustain a spinal cord injury at X level, then your life expectancy is Y years. And if you're 20 years old and you have the same level, it may be Z years. And if you're 70 years old and the same level, it may be B years. But those are all research-based, and there's plenty of data out there to support that. There are some places that require a physician to estimate life expectancy. When that's the case, I always ask. However, when I ask the physician, I say, according to these tables or this evidence-based stuff, what do you agree that this patient's life expectancy is somewhere in this range? And when they're faced with the actual data, they generally agree, because, face it, nobody can look at all data all the time, and the physicians are no different. So when I give them that data, they're very happy to rely on it. When somebody gives me a life expectancy that's really unrealistic, then I will put that in my life care plan, but I will also quote the data, and then I'll say, therefore, the costs and the expectancy in my tables are, there's two columns. One is for Dr. Smith's, and one is for the U.S. renal data set, or whoever. That make sense?
Okay, that's all the time that we have for questions. If we do have further questions, we can get them in contact with you to get some answers, Wendie.
Absolutely. I'd be very happy to talk with anybody. My phone number was on that slide that just disappeared and in the handouts.
And we can also, they can also contact TASA, and then we can get them the answers too as well with that. And this
Perfect.
webinar is eligible for CLE credit in California, Illinois, Minnesota, Missouri, New Jersey, Pennsylvania, and Texas. To ensure that you receive your CLE credit, please complete this survey at the end of the presentation.
Could I say one more thing, which I didn't get in, which is I think is really important?
Sure, go ahead.
For that. It's important to realize that most health insurance, including the Affordable Care Act covered plans, do not cover a large portion of what people need to have. It doesn't cover home care. It doesn't cover a lot of equipment. It doesn't cover a lot of stuff. So you're going to want to make sure you remember that when you're looking at damages for your clients. Thank you.
Okay, and also CLE certificates will be provided within 24 to 48 hours via email. In addition to being your best source for testifying and consulting experts, TASA also offers e-discovery and document management solutions, free interactive webinars, and research reports on expert witnesses, such as the Challenge History Report 2.0, the Professional Sanction Search, and the Expert Profile 360. I want to take this opportunity to thank everyone for attending, and most especially Wendie Howland for her time and effort in creating this presentation. If you would like to speak with Ms. Howland, or if you would like to speak with a TASA representative regarding an expert witness for a case that you are working on, please contact TASA at 1-800-523-2319. This is a reminder that we will be sending out a link to you with the archive recording. The archive recording will also be posted in the Knowledge Center on TASA's website. If you have any questions or comments, please email Carol Kowaleski. Thank you all again for attending, and have a great day, everyone.